Absolutely. Thank you for having me. Very much a pleasure to be here. And I am so excited to talk about some of the new offerings that we have and how we put them together and really trying to do it in a way that is meaningful for the clinician because of all those things that were said. I was going to say clinician first, maybe mother wife first, and then clinician after that, but whatever. A Venn diagram of those things that are there. And what we know is that we would love to have all the information that we need to make the most appropriate decision for our patient, but it can be confusing in terms of how do we actually do that in a patient care world. So I want to introduce to you today a couple of profiles. There are more than this that have been added to Rupa, so check them out if you have time. But today I want to focus on the female and the male wellness panel. And so as you eyeball these, what I want you to look at is, first of all, the amount of information that you're getting here. And I'm going to walk through that. CBC, a chem screen, you're getting DHEA and cortisol, a complete hormone profile, a complete thyroid profile, some cardiovascular markers, some immune markers, as well as nutritional markers too. And really, also how when we start with some of these basics that we have to have, right? We have to know if somebody is in liver failure or in kidney failure before we start treatment from there. But how can we start with these basics in a way that is cost effective and helps us to move the patient to that next step where they need to go? Here are some of the other profiles that are available, some of our adrenal stress and our complete thyroid. And if any of this interests you today, check back in. I'll be doing a boot camp that's going to be thyroid focused. I'm so excited for that, but it's going to be looking at how the thyroid interacts with adrenals and reproductive hormones, some of those interconnections, comparisons between, for example, hormone, serum, saliva, urinary, and a lot of things that we always have questions about. And also putting the profile together in a way that when we need to look at hormones, we can look at all of them together: reproductive, thyroid, adrenal, etc., and why that is so important. Next quarter, I'm doing a boot camp in terms of our food test. It's called the P88 dietary antigen test. And in Q2, this thyroid boot camp that I can't wait to do, that's going to look at all of these markers together and their interconnections. But today I want to just kick it off thinking about the difficulty with integrative medicine. If we want to participate, if we want to practice in an integrative, functional, naturopathic type of way, then we want to know everything about that patient and we want to individualize to that person in front of us. And so as soon as we want to do that, we need to know what's going on nutritionally. Is there inflammation? Is there toxic body burden? What about mental emotional stress, oxidative stress? What about infections? What about hormones? And then we're left going, okay, so what should I do next? What should I do first? Where do I go from here? And we, in some ways, we would say that we could have every single test out there and it wasn't cost prohibitive for a patient. Of course, we would love to do that, but that's not the reality that we live in. And we want to be directive. Even if we had every single test, it would be hard to treat every single part of every single test in a patient, especially if they are more complex. So how do we begin to piece it together? How do we begin to put it in a systemized way so that we can individualize for that person in front of us? And again, to me, one of the distinctions in terms of maybe integrative or function or standard of care is not even the pill, powder, or potion, but again, how we look at things. And so let's just take, for example, depression, and let's take that, for example, in terms of an ICD-10 there. And when we think about this, you know what? Absolutely, that could be caused by nutritional deficiencies. Is there something going on in terms of tryptophan? Maybe they're not getting enough protein. What about inflammation? We know if there's IL-6, that will block tryptophan's ability to go on and make serotonin. We know toxicity. We know if there's a decrease in glutathione in the brain, that this is highly associated with things like both anxiety and depression. Mental emotional stress, of course, would feed into this. I mentioned glutathione in terms of oxidative stress. We know infections could create cytokines that create this same inflammation that I just mentioned. And of course, anybody who's experienced any drop off of hormones can understand how that plays a role too. So then we're left saying, okay, should I order every single test in every single area? Of course not. We're going to take the history. We're going to figure out what's best for the patient. And then we're going to start with the basics because they do guide us in a direction that's meaningful in terms of more of a functional medicine workup. So as we look at our Kim screen, as we look at our CBC, as we look at some basic markers of function, we can absolutely rule out pathology, which we need to do in order to treat in a way that's medically appropriate. But at the same time, it can guide us into what tests are next. And while some of these things, for example, are just very basic. And so here's a little snapshot of a part of the profile. I'll show you the entire thing. But so these are some, of course, you would say these are basic markers. They're things that we're all familiar with. And so why am I even excited about talking about something that's just so Lab 101? And the reason that I'm excited about it is because I love this moment with the patient where you get that first set of lab work back, or maybe they come in and they have seen 4 doctors, 6 doctors, 8 doctors already. Maybe they bring some of this in. I think legally, medically, if it's been a minute, we need to reorder it. But so we get this information and they say, I don't know, I've had testing before. And this person said, there's nothing really there, not to worry about it. And so this is that moment where we get to dive in and where we're going to look at patterns that haven't been talked about before, maybe with something like alkaline phosphatase. And I do want you to notice that on the wellness panel, you're also seeing some description in terms of what it means when it's elevated, what it means when it's low, but also we've defined functional reference ranges and we give a description for when they're in that functional reference range too. What do I mean by that? In this case, AlkPhos 154, that would put you above this reference range. But we've defined those functional ranges within the range. And so when they are it's still in range, but high normal or low normal, you'll also get text that talks about some of the nutritional inferences that we can make from that. So here we are, an elevated liver enzyme, and elevated AlkPhos. That might be obvious. Both of these can come from the liver. We see multiple things that can come from the liver. This is probably what we're thinking about. But in terms of some of the things that we've defined functionally here, in terms of the test result, when somebody is high normal alkaline phosphatase, you'll see a discussion that talks about research like this. For example, alkaline phosphatase can come from the liver, but if on your test results, your patient's test results, there are not other liver enzymes elevated and AlkPhos is high normal, it talks about what else that could mean. That could still mean some beginning liver impairment, but the other place that we make, couple places that we make AlkPhos besides the liver, we make it in the bone. So if there's not a growth spurt, we also make it in the gut. And one of the major reasons you see an increase in AlkPhos is because it wants to detox right at the gut lining. And the major thing it wants to detox is lipopolysaccharides. And these come from dysbiosis, bacterial endotoxins. And so they're super toxic to the body. If they make it into our system, they travel through the portal vein. They get dumped right onto the liver. The liver doesn't like it. So the liver begins to make cholesterol and triglycerides. The lipopolysaccharides travel around the body. They can damage LDL to oxidize it, to make it that beginning form that starts to become a plaque. If it crosses the blood-brain barrier, it will interfere with the ability, again, to move tryptophan into serotonin, creating local inflammation. It will deplete glutathione. It is highly associated with depression and anxiety in the literature. So it's a direct gut-based connection that's very well evidenced in the conversations out there in the data. On our wellness report, when AlkPhos is high normal, it will talk about things like, yep, it goes up to regulate bicarb. So maybe there's something going on in terms of pancreatic enzymes, but it goes up to begin to detoxify lipopolysaccharides. It regulates gut microbes. It helps in terms of decreasing things that are pro-inflammatory and has anti-inflammatory effects, even decreasing toll-like receptors right there in the gut lining. Fascinating. You know what else increases toll-like receptors in the gut lining? Gluten. So this is one of the reasons, even outside of being allergy or sensitive, that gluten can bother people. It upregulates these toll-like receptors that usually bugs do that to call in more immune cells to the area to make things more inflamed. But it can happen right there on our enterocytes. And you'll see that in standard lab markers with a functional increase in AlkPhos, high normal. So then the text will begin to describe that and how this could mean there's some gut-based dysbiosis. And so a further workup in terms of looking at stool testing might be warranted. It will go on to look at patterns in all of the markers that are on there. Of course, we know that neutrophils go up when there's bacteria, when you're trying to fight a bacterial infection. But on the flip side, and they'll go down when there is a viral infection. That's the standard thing that we're taught in Lab Class 101, although COVID came along and broke that mold, right? Because we know it messed up the innate immune system. Instead of lymphocytes going up because it's a virus for COVID, what we saw was they went down and neutrophils went up, the exact backwards of what should normally happen with the virus. And so all of these things are worked into the logic, but low neutrophils could be because of something like a COVID infection, but it could be because of lower levels of B12 and folate. And we know that phagocytosis is going to go down. And so this will be talked about and then tallied in terms of the report. Anytime that there's a marker that's associated with a lower nutritional level, a calculation is made to show, okay, what are nutrients that appear to be deficient based on these test results? Okay, low red blood cell count. This is part of that CBC. Like I said, we got to do our basics first. Are you anemic? Because if you're anemic, that could mean you're bleeding somewhere, and we've got to rule that out before we can really go any further. Because if you come to me with fatigue and you continue to lose blood, I can give you all the adrenal support in the world, but I'm never going to get your energy level up. So we've got to understand where that's coming from. Once we've ruled out a GI bleed, but of course, that is discussed in the write-up discussion of potential blood loss. Could there be micro tears in the gut? Thinking about it from that standpoint. But yes, of course, they can go down because of not enough iron. But it turns out even B12 and folate can cause a low red blood cell count if they're low enough. Thiamine can do that as well, vitamin A, and all of these things will be discussed. So maybe you have a patient and their red blood cell count is low, and you knew that already from some iron. You've done things to try to increase the count. It still wasn't coming up. Now the text would talk about other nutrients like thiamine or copper or vitamin A, triggering those conversations. You'd say, wonder what your copper's like. So this might let you know that you need to go on to do more of a nutrient test with your patient in general, or maybe you ask some questions. Why would the copper be low? Have you been taking a lot of zinc? Is it cold and flu season? And are you just sucking on a zinc lozenge every single day? Yes, 3 or 4 a day. Okay. Possible zinc toxicity. While a lot of times this text are things that we might know that might be folded away in our brain, seeing them there can be just a really nice reminder in terms of questions we might want to work and areas we might want to follow up. Okay. So nutrition is one of those things that I mentioned, but what about toxic body burden? Sure. If we see low red blood cell count, but again, we're going to be looking for patterns. Is there also a low white blood cell count? What's going on with platelets? And I'll talk about that in a minute. Then that could mean, maybe some toxicity. Where do toxins like to go? Fatty tissue. What's fatty? Bone marrow is pretty fatty. If you've ever had it at a restaurant or been luxury to even have it on a burger, super fatty, right? And so that is where toxins like to store. So a common thing that we see with toxicity is that lower red blood cell count or even lower white blood cell count. And so the test will look for those patterns and share that part with you. Okay, if it's low, maybe that means you're not making erythropoietin as you should. So then the logic will talk about what are some nutrients that you need to make erythropoietin? What are some other hormones that you need to make erythropoietin? Testosterone and DHEA will do that as well. And so then reminding us, let's say this is a patient we're concerned about. There seems like their iron would be fine. They eat lots of beets and steak and dietarily, and they have they're taking digestive enzymes, so we don't think it's an absorptive problem. reminding ourselves, oh, it could be the signal to make the red blood cell. And part of those signals are DHEA and testosterone. Again, toxicity could be things from the environment, or it could be heavy metals. But it turns out that this can also trigger us to ask some other questions too, in terms of what might be the cause. So, a very standard marker. And if somebody were to just breeze through a doc in the box somewhere, they would say, oh, you're anemic, take some iron. But it's not the only reason this can happen. And they would continue to feel fatigue. And so just by having that conversation in the text, we're able to help pinpoint what else might be going on with our patients. Okay, high red blood cell count. This can go up with some methodologic issues, but there are other reasons this occurs. So when you see a high normal red blood cell count, our wellness report is going to screen you to think about, okay, what's going on with stress, because that can cause this to occur. How about checking in with some other things? So we'll make more red blood cells when we need to oxygenate the tissue better. What are some things that decrease oxygen? Of course, something like tobacco would cause more respiratory scarring. That would decrease oxygen. Our body would try to compensate by increasing a red blood cells. So some of this conversation right there, that would be cueing us off to respiratory distress, and again, cueing us off into understanding some of the nutrients that we might need more of. We need vitamin C in terms of helping connective tissue and some of this oxygen saturation, so it can point us in that direction, point us in a direction in terms of nutritionally, what should some of our next steps be. Okay, we know macrocytic anemia. Of course, this is our major place that low B12 and copper show up. The red blood cell continues to get bigger and bigger because it's not getting enough B12 and folate to tell the DNA stop, quit making it bigger. And so it continues to enlarge in size. And a bigger red blood cell means we're making less of them. They're not as great at carrying oxygen around. And so it's problematic. But again, there are other reasons we get macrocytic. And I'm sure you've all had this happen with patients. You did even the injections of B12 and folate, and they're just not recovering. They're not recovering. Well, just having some text right there to remind us, okay, copper and thiamine could play a role here too, as can toxicity, looking for some other reasons that this might occur. Again, how about low? Now the algorithm is going to look for these patterns. Like, what about low white blood cells, red blood cells, low platelets? That means low stem cell turnover. That could mean more toxicity, but it could also mean poor differentiation, taking that stem cell and moving it in the direction it should go in. Vitamin A and D are big players there, and also reducing oxidative stress is important as well. We can begin to look at these basic markers like AlkPhos, like a white blood cell count, like red blood cell count, to decide, okay, is this my gut patient? Is this my detox patient? Are the white blood cells elevated? Is this more my infectious disease patient? We're not even guessing about the hormone part because it's right on there. And so really starting to get that idea of, where do I go next? Is it the stool test? Is it food sensitivity? Is it organic acid? Is it something more like looking for like some type of hygienics, or looking at more mold profiles? What's my next step, rather than saying, I'm just going to order everything on everyone? And those practitioners, we've all seen them out there, and a lot of them do have a fair amount of success, because the more we know, the better. But patients can also feel, we can feel like, but is that the right approach? If I could figure out what's most appropriate for this patient, wouldn't that be better? And from a patient care perspective, like when people come in, they go, oh, I had 5 friends go there. They all 5 did the same $20,000 worth of testing. I'm looking for a more individualized approach. This is how we can use those basic markers to get to that place. Okay, so in terms of algorithmically, what are we looking at to see that kind of gut-based change? Okay, so what's going on with the CBC? Are they really struggling to absorb their nutrients? And that could point us in a gut-based direction. You get points for that high normal AlkPhos that can go up because of lipopolysaccharides. If your vitamin D is low, some assumed malabsorption. Looking at monocytes, eosinophils, and basophils, not elevated, but a calculation of all 3 together. And then our all three together in the upper half of a reference range, because more often than not, these all come back at 0 or point 0.1 or almost nothing. If all three of these are half of the reference range and up, then something is activating that innate immune system. And a really good guess for a first kind of, so not saying they're sky high, like not just frankly high. Okay, sure. We're thinking allergies, we're thinking parasites, but high normal in all three of them. What would be causing that? Gut-based permeability is a great way to begin to ignite the systemic immune system. And so doing calculations that help us to see that. CRP, of course, goes up in people that are more at risk for cardiovascular disease and stroke. But what's one of the reasons for that? As our gut gets more leaky, becomes more leaky, there'll be an increase in IL-6. That IL-6 sends a signal to the liver. The liver begins to produce CRP. So we see therapies that treat leaky gut, like, for example, immunoglobulins that block zonulin from binding to tight junctions and decrease a leaky gut. We see these immunoglobulins that work mainly in the gut decrease a systemic CRP, helping us to understand that, yes, leaky gut can cause this to be elevated as well. Okay, we look at B12 and folate, and we look at a ratio of that. So when that ratio is shifted, when you see a decrease in B12 but an increase in folate, usually like, yeah, but they're B vitamins. If it was HCl, shouldn't both of their absorption be compromised? Why would B12 be low and folate be high or normal? That's the kind of skew that you'll often see with more dysbiosis, in particular SIBO. Dysbiotic bacteria loves to gobble up some B12. Another little clinical pearl around that, if you see someone who feels worse after methylcobalamin or even methylated B vitamins, they could have problems with methylation, but they also could have dysbiosis because, again, dysbiotic bacteria just really struggles to activate B12, so it loves that methylcobalamin. If you're working in a lab and you really want that bacteria to grow, you definitely plate it with good heavy hand of B12 and some B vitamins in there. And so again, these patterns can tell us about, okay, there's something gut-based going on. Do you have thyroid antibodies? Okay, autoimmunity, that often happens with leaky gut. And this is not just something our community talks about. I can point to multiple studies that come to that same conclusion in terms of gut-based permeability being a reason for increased thyroid antibodies. We'll talk about it in thyroid boot camp, and we'll even look at, for no other reason than just to cut and paste some slides, right? Don't people say, oh no, gluten can't have anything to do with thyroid. I will load you up with references that show that removing gluten can be something that lowers thyroid antibodies as well. And how about low cholesterol? Not something we see that often, but when we do, probably a malabsorptive patient. So back to some of those gut-based patterns. So again, all of these things get fed into the calculations to give us some results there. I wanted to spend some time talking about albumin, right? That's not very sexy, Cheryl. Albumin, it carries a lot of things around. Okay. Maybe if it's low, they didn't get enough protein. Okay. No, there's a lot that we can learn from albumin. And true, you're absolutely right. Low protein. Albumin moves more quickly than protein. So a low albumin happens faster than a low total protein. But it will also happen when there's more inflammation. And it can happen from low grade infection. So it would feed into that part of the algorithm. And it can be a reason to increase CRP. And now, again, when we're looking for nutritional inferences, elevated CRP is going to tell us that that's an indication for more vitamin C. Interestingly, they compared it to vitamin E. So you might think, would just any antioxidant do that? And no, vitamin C was much more effective here in terms of lowering CRP. So again, remember we talked about when red blood cells are high, it can be a need for vitamin C. Okay, so when CRP is high, it's a need for vitamin C. So again, these things are going to feed into that calculation to give you those nutrient recommendations. And albumin, yeah, it carries a lot of things around. So when you see a low albumin, you know that person needs more antioxidants. Why is that true? Because albumin carries thiol groups. These are also known as mercaptans, and that means they capture mercury. That's where that name comes from. And so those thiol groups predominantly come from glutathione, maybe some N-acetylcysteine. And so when you see a low albumin, and maybe you had normal glutathione, but you're not delivering it to the tissue. The major carrier of glutathione is not working like it should. So we know we've got to really load those people up because they're going to need extra to make sure it gets to where it should be in the system. And so when you see a lower albumin, yeah, you're thinking again, okay, what are some antioxidants? And all of these show up and are of value when albumin levels are decreased. And again, it guides us to do our glutathione therapy. So now you see a low albumin. We're going to look at some other markers within the reference range, but a low normal white blood cell count. Within the reference range, but low normal platelets. They can't move glutathione around, and some of the major reasons that the low white blood cell and the low platelets occur are because of toxicity. Now, okay, I need to move in a detox direction, looking at markers of oxidative stress, looking at what does their glutathione look like versus maybe moving more in a gut direction. And so not only that, not only does it carry glutathione around, but it's also associated in terms of being a marker of longevity. High normal albumin is one of the markers most associated with longevity. It's cheap, it's easy, it's there on every screen you do. It's just having the information to be able to make the patient aware. I've always looked at albumin less than a 4, and so that's the functional cutoff range. Down to 3.5 is when it's frankly low. And then I've always talked to people about, yeah, you're probably not getting enough protein. Maybe you need more digestive enzymes, but it's so much more than that. And this one's funny to me because some of the best actuary evidence in terms of how long are you going to live, don't go to the scientists. They're working with the scientists, but the people that have some of the best data around this are insurance companies, right? Follow the money. They're going to lose money if they can't predict when you're going to die. So it is very much in their interest to predict that as much as possible. So here from the Journal of Insurance Medicine, they say, hey, look, not everything with age predicts mortality. You could have gray hair, you could have wrinkles, you could bald, and that might indicate a chronological age, but that doesn't have a correlation with premature or delayed mortality. And then they go on to say, this is not the case with albumin. Even though albumin drops with age, when they looked at this study with 1.7 million insurance applicants, and they looked at people who had the highest average serum values for their age group, they had the lowest risk of mortality. And the people with the lowest serum albumin had the highest risk of mortality. So again, they're betting their whole business on all of this. And I would say that insurance companies have been pretty successful at making a decent amount of money. So they probably found some data points that are fairly meaningful. Even if you don't want to hear it from them, here it is from Annals of Intensive Care. And the title's down there at the bottom, Role of Albumin in the Preservation of Endothelial Glycocalyx Integrity and Microcirculation. Another reason it goes down is not just protein, although that gives you some calculations in terms of your nutritional part, but another reason it goes down is because it will go down when there is damage to a vessel. So we began to learn a lot more about this. We really saw a sped up version of this as we walked through COVID and we walked through cytokine storm. At first, we're like virus, upper respiratory infection. And that's not wrong. That's right. But then we started to see, but you're dying of kidney failure too, or all of these people that have dizziness when they go from sitting to standing with long COVID. And so we began to realize it was more of a microcirculatory condition. And it was these cytokines that were damaging the vessel. You could have a quick burn of cytokines, but you can also have a long, slow burn like Lyme or like mold. And what do we know in terms of Lyme disease? They're more likely to have POTS, so issues in terms of orthostatic hypotension. And so again, that dizziness when you go from sitting to standing. Why? Because those cytokines damage the vessel. And the part of the vessel they damage is this glycocalyx. And that glycocalyx sends a signal to tell us to make more nitric oxide. It tells us what to pull from the blood supply into the tissue space. It keeps things out of the tissue space that shouldn't be there. So this glycocalyx, it's one of those barriers that's more than a filter, a lot like our gut. It regulates that tissue space. It regulates what the white blood cells are doing, whether or not they get stuck there or whether or not they move out to deal with infections. A lot of activity of this glycocalyx that determines how long we live. The more you can deliver oxygen to the tissue, the healthier tissue is going to be, the longer you're going to live. When that begins to decline, albumin says, I need a healthy vessel. And albumin begins to marginate to the periphery of the vessel to continue to give that vessel structure that the glycocalyx was giving it. So now you go and you draw blood, and the albumin is low in your tube because it was all marginated to the periphery of the vessel because it was trying to provide structure there. So we'll also see low albumin with microcirculatory issues. And so when we are trying to decide, is this dizziness because of blood sugar, or is it because of a vascular issue that I'm seeing, like in this long COVID patient? Is this long COVID patient having microcirculatory issues? Looking at that albumin is a beautiful functional marker for that. If it's less than a 4, then the test is going to come up with a discussion about how this could mean your vascular system is damaged. This can be a reason for less nitric oxide. This can be a reason for more high blood pressure, et cetera, et cetera. And not only our insurance friends, but here also and from Journal of Nutritional Health and Aging, they were looking at nutritional factors of longevity and the quality of life in elderly Japanese. And what they found was that they looked at all these markers, and they said the one that was most associated with longevity was high normal serum albumin. And they looked at cholesterol, and they looked at markers of like alpha tocopherols, vitamin E, and oxidative stress, and all these other things. But the thing that mattered the most to longevity was albumin. And the article was beautiful because it wasn't just academic. It said, what can we do about it? And they did go on to talk about, as they gave digestive enzymes, people absorbed more protein, so they were able to make more albumin. We would know that as we work on the vessel, as we use things that build the glycocalyx, so maybe things like hyaluronic acid or N-acetylcysteine or various seaweeds that build that glycocalyx, glucosamine builds the glycocalyx. We would know that these things are indicated based on little old basic markers like albumin that normally we were just saying, if it's low, there must be a liver issue because it's made in the liver. All that's still true, but there's so much more we can learn from these markers, especially, sure, you were made in the liver, but you carry glutathione around. You support the vessel. You're associated with longevity. And so when we have this information at our fingertips, much easier to communicate to the patient at large. Okay, so what else would it okay, we might see this lower albumin. Why could that be occurring? Other things that damage that glycocalyx. Histamine does that. Metal proteinases do that. All these markers of inflammation do it. So again, a lower albumin tells us, this could be a patient that's having more inflammation. Now let's figure out where that inflammation is from. Is it gut-based inflammation? Is it something else? Even food sensitivities can damage the glycocalyx. Here in this study, they were looking at the glycocalyx. Actually, it lines vessels, but it lines the gut too. And they did strategies to rebuild the glycocalyx. And they saw these kiddos not have diarrhea anymore. But interesting that food sensitivities were the reason for the glycocalyx being damaged in the first place. Okay, so other nutritional inferences. I said if CRP is up, that might be an indication for vitamin C. But also discussed in the text there would be, curcuminoids might be something that you would reach for. Or when C-reactive protein is elevated, it inhibits endothelial nitric oxide synthase, so we make less nitric oxide. When we make less nitric oxide, more problems in terms of hypertension, plaque formation, vascular compromise. And so in the indications, you would see, you might need curcuminoids, or if there's problems in terms of blood pressure, we might be thinking about things that improve nitric oxide like beets or citrulline, et cetera. And so doing these calculations, looking at these various pieces together. So other markers that we would think about in terms of liver function, for example, do you have normal but low normal albumin, slightly increased bilirubin that will go up when we need more glutathione, decrease BUN, decrease cholesterol and triglycerides because they're made in the liver? Maybe you would see increased ferritin, but also a discussion with ferritin in terms of, yes, being inflammatory, but gosh, is it so helpful to have those functional ranges for ferritin, right? It's a huge range. But really, we don't want people on the upper end of that range. But where's good enough to have decent energy? Depends on who you are. If somewhere between 60 to 80, depending on if you're male or female. So delineating that in the wellness reports, what's that target if their ferritin is low to have good energy, but not overdoing it in terms of more oxidative stress. Also, if ferritin is high, not only a discussion about how that can go up with infection, how that can go up because of inflammation, but ferritin specifically suppresses lymphocytes. So now you're more at risk for viral infections out there. So helping the patient understand all of these connections between the various markers that we see. Decreased uric acid, that might sound funny to you because you're like, wait a minute, I only care about uric acid if it's high. That means gout or even high normal will start flagging in terms of you'll see discussion of metabolic issues there. If uric acid is high normal, we know that it can inhibit AMP kinase, that it can inhibit that pathway that gets turned on by exercise. That pathway that gets turned on by caloric restriction is inhibited by uric acid. So even high normal uric acid is associated with metabolic syndrome, and there's an argument that it's more sensitive than even insulin or hemoglobin A1C. So we understand on the high end, and there's a functional range and there's a gout range, but why would we care about a low range? Because we need to make it, and the predominant place we make it is the liver. But why do we make it? We make inside the cell, you make uric acid when you are under oxidative stress. The classic way we would think about this would be like aged meat, then the meats and the wine and wheat. Wheat is a huge one for increasing uric acid. Beer, all of that are reasons are right for gout and high purine foods, gout. And when the cell sees these things that are creating oxidative stress, it protects itself. Inside the cell, uric acid acts as an antioxidant. But then you make more. Now it bursts the membrane. It spills out from the cell. And so when you're measuring it and the serum is high, it's because there's been too much cellular load and the cell's trying to respond to that now. And now when it precipitates out into the joints, it's not supposed to be there. It was supposed to be intercellular, not in your big toe. And it hurts a lot once it's there. But in fact, they credit the human race going from 4 legs to 2 legs to uric acid. That antioxidant effect meant we could put up, well, it made our brains bigger. And that antioxidant effect meant that we would live longer. And so it's associated with our evolution to a 2-legged creature. So we need it. It's an antioxidant in the cell. So if it's decreased, that points to various pathology as well. So calculations of these things to move us in directions. And again, we've all seen people that have, for example, low normal, not elevated, but not low, but just low normal. So here's the range over here. And look, that's pretty tight from about a 7 something down to about a 6 something, but in quartiles. So looking at those distributions. So by the time it's still well within the reference range, right? They'll be getting down to less than a 3 or so to be outside of it. You're still well within the reference range, but still by the time you're about 6.5, you're in the bottom 25%. What they saw, and these were great studies, and this was an article by Dr. Joe Pizzerno from Integrative Medicine, and he just did a fabulous job here collecting this data. What they saw was what you do see a decrease in a white blood cell count when there's more PCBs, OCPs, organophosphates, etc., but within the reference range. So somebody comes in, they have huge toxicity, or maybe not huge, some toxicity, or it worked around airplanes, but not like on the tarmac kind of thing. And we're trying to figure out how related it is to their pathophysiology. We can look at these basic markers to decide, do we need a heavy metal? Do we need an environmental toxicity? Which direction do we go next? And if you see low level platelets with low normal white blood cell, this is big in our criteria in terms of being more toxic. So I always think of this as little things are very susceptible to toxicity, right? Our little fish with mercury, our little babies within us, right? All more fragile. They concentrate, and so that makes up more of their being once it's in there. proportionally, little platelets too. So as they go down within the reference range, we start to begin to suspect potential toxicity. Okay, so how do we sort it all out? Also, some ratios on there. And that for example, just even within the reference range, increase in ALT, but with a decreased albumin could mean more liver dysfunction or oxidative issues, maybe conjugation problems, meaning problems with phase 2 detoxification. So indications to move in that direction. And then we can look at various liver markers to tell more where we think it's coming from as well. But when we do actually see a low liver enzyme like AST or ALT, you'll look it up. There's not a lot you find. Okay, it turns out that tells us something as well. So these are transaminases, and they require B6 to do that transamination step. It's a cofactor there. So when we see low AST and low ALT, we know we need more B6. When we see more low alkaline phosphatase, we know we need more zinc and magnesium. Both of those are cofactors to stimulate production of alkaline phosphatase. Interestingly, when you see it high normal, zinc still wouldn't be a bad idea because you want to support the ability to keep making AlkPhos, to keeping lipopolysaccharides out of the body. And in addition to that, zinc is bacterial static. It will kill the bacteria that's making the lipopolysaccharides. So again, a nice twofer there. Zinc will support the increase in AlkPhos and will kill off the bacteria that's causing it in the first place. So there can be other reasons for AST abnormalities, and we're going to include those too. So if it's decreased, it's not just B6, but that can happen with dialysis. That can happen with gonadal deficiency. And increases in AST can happen outside of the liver, but it can also happen with deficiencies of certain hormones like progesterone, and also even lower levels of vitamin E can be associated with an increase in AST too. So making sure we're really drilling down into all those pieces. But again, ALT, liver enzyme, but no, and again, we're still looking inside the reference range. We're just looking at within the reference range, were you with the lowest quintile or the highest quintile, and you see the line goes up when people had more DDT, when they were exposed to more organophosphates, when they were exposed to more organochlorides and more pesticides, ALT does go up, but within the reference range. Here we're looking at now ALT to heavy metals, so it looks a bit more responsive to metals within the reference range. That top one there is more PCBs that cause the biggest spike. And then we see after that, we see also PCBs. We see lead is up there. So cadmium hung the bottom. It didn't really change ALT that much. But again, so we can even pinpoint which toxins are more likely to cause this. And those are listed in the descriptions that are included as well. And so again, we can think about even an AST to ALT ratio that gets calculated. Sure, non-alcoholic fatty liver disease. And at first you might go, wouldn't that be toxicity? And it would, but you still get some gut points for that as well, because your number one reason for non-alcoholic fatty liver disease, right? Non-alcoholics, we already ruled out alcohol, is lipopolysaccharides. That LPS, that dysbiosis that comes from the gut and gets dumped on the liver does not only, I mentioned it increases triglycerides and cholesterol. Those are fats. Those are lipids. That's part of that fatty liver piece of it. And so again, this can tell us about gut work that needs to be done as well. So within this wellness panel, you get what's seen there, that comprehensive thyroid panel with antibodies. So you're not guessing about that. And finally, right, rather than every single time having to explain, a TSH of greater than 2.5 can still be subclinical hypothyroidism. I know it's not out of the reference range, but it's still meaningful. We flag that. The test is going to alert your patient to that it's high normal. And that this still means that there can be some issues there. And so the education happens for the patient right there on the paper. When they get home and have forgotten what you talked about, it will tell them about that. And again, discussion of things like iodine can be used to decrease TPO antibodies, discussion of things like tyrosine and zinc and ashwagandha and glandulars increasing free T4. So just very nice circle material so they can see how much nutritional piece goes into all of what happens with the thyroid. And again, these are things that that are on Rupa, and part of that, these might be included. For sure, the female and male wellness panels are the 20% off. We might be including those as well. I'll make sure I tell Adrian so he can put that in the email. But yeah, we just want you to know that we're doing some of this. But the female and male wellness include the thyroid. They do not include a salivary cortisol, but they do include serum cortisol and DHEA. So right off the bat, we can begin to get a picture of where things are at. So we also do a calculation in terms of T4 to T3 conversion. So if T4 is higher than T3 by a certain factor, that means you have poor conversion. And there's a discussion there that will tell the patient, yep, that means that you could be lower in nutrients like zinc and selenium. Now, we also do hyperconversion if you have low T4 but high T3, which is rare, but here and there you see it. And you're like, I wonder why that would happen. Cadmium likes to do that. Now, most metals will inhibit enzymes, so it will decrease this conversion, but there are some that do have that opposite effect, cause this hyperconversion. And cadmium is also estrogenic, by the way. But of course, all of this conversion happens in the liver, so this could mean you need more detox work. Points are calculated for that. Turns out cortisol can inhibit this as well. Oxidative stress can inhibit this. Even low bile can inhibit that. I know that seems very odd. Good. Let's figure out if there's a problem with bile, because it is one of the major ways we detox. And we've got to be excreting bile not only for detoxification, but it turns out there are bile metabolites that directly interact with the mitochondria. So low bile doesn't just mean you're not going to absorb fats. It means that. But we're learning so much more about bile. Did you know there are receptors for bile in the brain that increase brain-derived neurotrophic factor? There are receptors in the mitochondria for bile, so it's wild. All of these things that we thought are just gut-based pieces, of course, do things all over the body. And again, we can look at this to get an understanding of where to go next. So we talked about poor conversion, but also as we make thyroid hormones, we make higher levels of hydrogen peroxide, free radicals. And these free radicals, if we make too much, will damage our thyroid hormone, them up, make them look so if you see more antibodies, TPO thyroglobulin antibodies, you know that the activity of your glutathione peroxidase is not where it should be, and that there is more of an oxidative stress issue. Again, the antibodies can include a conversation about how, yes, this could be leaky gut. Yes, this could be low adrenal function. And yes, this could be a concern with oxidative stress, so that your patient understands why I'm here for a thyroid test. I want to know, I read thyroid makes you tired, it makes you gain weight. That's all I want to know about. And so you see these things are low, and now they say, fix it. And so you can talk to them about, okay, let's look at some of these basic markers. What else do I need to fix it? These antibodies indicate you could have higher levels of oxidative stress. Let's think about a glutathione level. These antibodies indicate autoimmunity. Let's think about some food sensitivity testing or some stool testing. And so it can guide us to those next steps of where do we want to move in terms of a functional medicine workup. I can't make it through one of these things without saying something about magnesium, so we measure it. I think that it's just a great entry conversation for people to begin to understand how much magnesium does throughout their body. My very first patient that I ever treated and out after graduating, not supervised, out on my own, was a kiddo who was having just horrible tics. And he was just suffering terribly. And it seemed very extreme for me for a first case to be dealing with. Of course, I was nervous about it. And I managed to say magnesium because, and it made all the difference for him. And meanwhile, like his mom was saying, okay, we might need a heavy metal test. We might need this test. We might need that test. And I was like, we have some basic information. Let's start with that. And that resolved the tics. And so again, it can streamline things. It's hard enough for things when people are sick, it's hard enough. So running a million tests is insult to injury sometimes. So moving in the right direction is important. Okay. Yeah. In case you needed a list of all the reasons that magnesium can be lower. Yes. So many medications can do that. Here is a few more reasons for magnesium deficiency. Suffice it to say that there are a lot of reasons that we become deficient, and I could just cross all of this out and just write stress in big letters across everything, and that would probably be adequate to explain why so many of us are deficient in our magnesium. We look at vitamin D, which again can open up lots of good conversation. If they go, but I take 5,000 IUs of vitamin D. Why is my level low? Malabsorption. We're back to a gut-based piece. But okay, maybe they're getting good digestive enzymes. The gut's good. Why is my vitamin D low? Because what's measured is the 25 form of vitamin D. When there's more infections, we will hyperconvert to 125 because it's more active. And so if they've been taking vitamin D, it's not going up. This could be another reason as well. Also, magnesium's a cofactor in there too. So again, gives us a lot of guidance. And here, some piece in terms about how vitamin D is protective to the liver in terms of diabetic issues. It could be part of detox as well, good old vitamin D. And here talking about vitamin D, as vitamin D increased, it decreased cardiometabolic risk factors and metabolic syndrome in postmenopausal women. So it's not just hormones that do that. We can make a lot of improvement with things like normalizing vitamin D and a short list of conditions that respond well to vitamin D. And then, of course, we can have lower levels of phosphorus too. So looking at some of those interactions as well. So again, giving those optimal ranges and the standard ranges. So a lot of that work is done for you as you look at these things and giving some explanation of various low and high anion gap. Here are the hormones. So this is what would be on a female wellness panel. If you're doing a male wellness panel, get rid of FSH and add in a PSA instead. But again, nice to have right off the bat. And we're going to talk about these interconnections between thyroid hormone and adrenals. And so you would have both of these markers from the wellness panel, male or female. So let's say you see that pattern. They've got great DHEA, but their testosterone is in the tank. And you're like, that doesn't make any sense. DHEA should convert to testosterone. If this is normal, then this should be normal as well. What would cause a block? It's not a lack of magnesium or B6. It turns out stress shuts down this conversion. So in a world where you see high DHEA and low testosterone, your body is saying, we are in a state of stress. We have more inflammation. We need to retain our DHEA. We are in a state of stress. We do not need to procreate. Get rid of that testosterone. And so this pattern then will allow you to say, you know what? I think we need to look at this in more depth. Let's start some things, but I want you to do an adrenal stress test too, because clearly we're seeing some stress implications in terms of your pathophysiology. And this could help you in terms of things like weight management and menopausal management. I just saw this interesting study yesterday. It was small, but a handful of people that did bioidentical hormone replacement and a handful of people that just did DHEA. Both sets had low DHEA, and the group that did DHEA did as well as the bioidentical hormone. So anyway, just points to the fact that having DHEA soon can be so useful. DHEA, we know it's low in lupus. We know it increases Treg cells. It has a lot of immune balancing properties to it. Here they talk about how it's anti-inflammatory. It decreases IL-6, decreases TNF alpha, but is not immune suppressive. It also decreases viral division as well. And so again, making sure DHEA is normal is not just for stress response and not just for energy, but immune function, menopausal management too. And then finally, the panel finishes with giving you a grouping of, okay, what's the biggest deal for this patient? And then it'll give you a write-up of the reasons, what markers added up to give you this picture. So now you can say fractionated lipid panels, or I'm concerned. You told me about that family history of hormones and you've got some imbalance here. So maybe we need to look at how you are metabolizing some of those things. And so it gives us a roadmap of where to go next. So ultimately, it includes CBC, ChemScreen. You've got your D, your B12, your magnesium, your folate. You've got all of your hormones on there, some cardio markers, hemoglobin A1C. Are they oxidized? Are they glycated? Are they stressed? Are they nutritionally deficient? This moves us in that next direction so we know what steps to take. So here's what that looks like. And again, 20% off until the end of January. We'd love to have you try it out and see what you think. And I will go ahead and stop there to make sure that I have time for Questions?
Hi, everyone. We hope you enjoyed this class. If you're a practitioner, make sure you go sign up at rupahealth.com. And if you like this video, don't forget to like and subscribe.